So for those of you that don't know me, I am Sarah Seager, Senior Director of Analytics and AI at IQVIA. So this session is a panel discussion, and it's around the lessons learned from OHDSI network studies. So we have four wonderful speakers. So first up, we have Marc Suchard from UCLA. And he will be talking around insights from legend, type 2 diabetes. Marc, please.
Yes! I'm going to talk a little bit about what legend and the legend.
We're testing you.
We really are.
Yeah, keep going.
Nice. Okay. Well, without some slides, I'm going to talk a little bit about what the Legend Initiative has been doing. Maybe we have some. And in particular, we've been focusing. There we go. Woo! Go again. Go again. Talking about treatment for diabetes. So the American College of Diabetes every year publishes standards in care. And these standards in care provide treatment guidelines for individuals who have elevated blood sugar. So amongst those individuals, the first line treatment is metformin. But often metformin alone isn't enough to manage an individual's elevated blood sugar, which might lead to systemic damage to the small blood vessels in an individual. So the guidelines suggest elevating with a second-line agent, but they aren't very specific about which second-line agent each individual should consider taking. These agents can be broken up into 4, maybe 5 or 6 different second-line classes: DPP-4 inhibitors, sulfonylureas, GLP-1 receptor agonists, and SGLT2 inhibitors. There have been limited randomized controlled trials looking at the comparative effectiveness of these different agents. And so guidelines are a little vague and not terribly informed on which agent a specific individual should start on. However, there are some randomized controlled trials that look at these agents relative to placebo. And most recently, they've identified that the now called cardioselective groups, the GPL1 receptor agonists and the SGLT2, do reduce an individual's cardiovascular risk. So it is suggested that individuals with known cardiovascular disease should start on one of these agents. But no randomized controlled trials have compared these agents to each other or compared them to the non-cardioselective agents. So there are a number of questions that we in the community might want to ask. Are patients with cardiovascular disease really starting with these cardioselective agents as recommended by standard of care? And are these cardioselective agents really comparatively more effective or at least safer than the non-selective agents? In order to answer this, we're going to use a legend approach, or a large-scale evidence generation and evaluation across a network of databases. Very briefly, legend is a guiding principles-driven enterprise to deliver verified and open evidence at scale. I'll go into more details on what those principles are tomorrow in the tutorial, but for now, what you should keep in mind are the 3 R's of good observational research, which should be rich, rigorous, and reliable. In order to do this, we've examined the medical records from almost 5 million adult diabetics who are currently on metformin and have never previously taken any other anti-glycemic agent. So these are the individuals who are just now initiating one of these 4 different drug classes with and without cardiovascular disease. And these individuals come from 19 different administrative claims and EHR data partners around the world. So congratulations to the network for pulling this off. It's a really global enterprise. Whoa, that's quick. Our first examination was looking at which of these agents are individuals with cardiovascular disease really starting with. Are they starting with the cardioselective agents or not? This work was recently published about a week ago in BMJ's new journal, BMJ Medicine, and taking my several $1,000 APC charges, they were kind enough to turn this into a visual abstract. Unfortunately, I don't feel the visual abstract actually captures the main point of the paper. The main point of the paper basically says there is large variation in the use of these cardioselective agents across different cardiovascular populations. And that's not terribly surprising. Across different healthcare systems and different countries, we have different priorities. What is, however, more surprising, perhaps the reason why BMJ was interested in taking this up, is the uptake is actually lower in the US compared to non-US sources of taking cardioselective agents. And it's even lower in the individuals with known cardiovascular disease, exactly the individuals who we might suspect the cardioselective agents are going to be most helpful. This work was led by two early career researchers, Lovedeep and Arya. I haven't seen you yet, but hey, love you guys. Moving on to looking at the comparative effectiveness and safety of these agents, an area where the randomized controlled trials are lacking. The legend principles basically say we're going to do this using best systematic practices. And in that case, we'd like to develop a new user cohort design so we can emulate the target trial or that randomized controlled trial comparing these agents, which hasn't been and probably will never be done. Using large-scale propensity score adjustment that helps us control for measured and unmeasured or indirectly measured confounding across a suite of large number of negative controls, which allows us to learn both about the amount of residual systematic bias that exists and control for that in our estimates. Of course, this is all backed up with rigorous diagnostics across all data sources, which we'll hear about tomorrow in the tutorial, that help improve reliability. The plot that I have over on the right is looking at the comparative effectiveness in decreasing the risk for major cardiovascular events across the major drug groups. So in this case, this plot is comparing SGLT2 versus the GLP-1 receptor agonists. And what we see up in the upper left part of the plot is that the SGLT2s and the GLP-1s are almost equivalent in terms of their cardiovascular risk profiles. Now, this is moderately unexpected. When we started this work, there was a belief in the community that SGLT2s were possibly better in terms of preventing heart failure. But in the last couple of months, there was a publication of a randomized controlled trial that it supports our findings that the risk of heart failure is comparable between these two drugs. We've also been able to fill in evidence that randomized controlled trials will not look at. And that's that in terms of the risk of major cardiovascular events, that risk is decreased amongst individuals taking the GLP-1s compared to the two different, what we call the non-cardioselective agents, the DPP4s and sulfonylureas. And this is very informative since no head-to-head comparison has been done previously across those groups. It's important to remember that, Legend type 2 diabetes is also a very rich and it's an open resource. Our study did not just focus on major cardiovascular events, but supported 32 different outcomes, including the cardiovascular that I've talked about, but perhaps more importantly, safety profiles, which help us judge the relative utility of drugs which are just as effective, and a number of patient-centered outcomes, which become particularly important to you and me as we decide which drugs we want to start. As an example of that, an early career researcher, Carlin from CityApp, is leading a manuscript right now, which is looking at the relative risk of acute pancreatitis amongst these drugs and diarrhea, nausea, and vomiting. The stars there, I've bucketed around the meta-analytic results comparing the different drug classes for each of those outcomes. And as you can see from these results, GLP-1s, as expected, do have an increased risk of individuals reporting severe diarrhea, nausea, and vomiting. But perhaps the larger safety question was, is there an increased risk of acute pancreatitis? And I believe the answer is no. In addition to looking at a large number of outcomes across these profiles, we're also looking at multiple populations. So our results can be stratified by gender, age, race, cardiovascular disease, renal disease, and other factors that are particularly important. Finally, Legend is trying to be community and regulator responsive. There was a recent publication of a case-controlled study that alerted the European Medicals Association to a potential association between thyroid cancer and GLP-1s. In response to that, our mid-career researcher, Daniel from Dundee, delivered a short report to their pharmacovigilance risk group, looking at a large number of sensitivity analyses, so judging different assumptions that we might make about this process, that show no increased risk of thyroid tumors for individuals using the GLP-1s. Finally, there are many emerging directions. We're looking at patients with renal disease, with heart failure, older adults, risk differences in women, and most importantly, across these differences are a large number of opportunities for all interested parties. And that means you and you and you and you. Please get involved. No work is ever done in a vacuum, and almost no work gets done by me these days. I owe a great deal of this to our legendary members on type 2 diabetes, but particularly Arya, Fan, Lovedeep, Rohan, Daniel, and Carlin. I'd like to just conclude by saying many of us, including myself, are looking for postdocs to start at a time flexible. So if this looks like a good direction for you to go in terms of your academic training, please reach out to me. And thank you for the time.
Okay, thank you very much, Marc. Okay, next up, we have Cindy Kayev from Hopkins University, and she will be talking about the anti-VEGF exposure and the risk of aortic aneurysm.
Full screen. Sorry, I'm a Mac.
Thank you to the organizers for the opportunity. So this talk will be a little bit different. I'm going to focus more on the lessons learned from the process of running a network study. And I think it's important to share my background so you know, to give you a sense of the perspective that I'm coming from. So first and foremost, I'm a clinician. I don't know how many of you out there in the audience are clinicians. If you can just quickly raise your hand or stand up, that would be awesome. Yes, thank you. So I'm talking to you. And my other perspective is that I'm pretty new at this. So if you look at my panelists and we plot the number of network studies successfully executed by folks, everyone else is probably somewhere up there and I'm all the way down there, which is okay. It just means I have a slightly different perspective, and things that I'm going to highlight as being really hard, my co-panelists might say, psh, that's a piece of cake. So I'm looking forward to learning from them. So hopefully through all of this, I will start to demystify the process of doing a network study and convince you, particularly those of you who are clinicians or who are new at this, that it's really rewarding and you can do it too. And so just briefly about the project itself, the reason we started doing all of this is because anti-vascular endothelial growth factor medications, when given systemically, have known adverse kidney side effects. It can cause acute kidney injury, it can cause proteinuria, which are major risk factors for kidney failure or end-stage renal disease, as you guys heard about earlier today. And we also use these medications to treat a number of blinding conditions by injecting it directly in the eye. And when we do that, there's still systemic absorption, obviously a lot less than we were giving it intravenously. And the degree of systemic absorption is different depending on the medication. It's the greatest with bevacizumab and aflibercept, and the least with ranibizumab because it cleared the fastest from the bloodstream. And so this has led a lot of practicing retina specialists to preferentially choose ranibizumab in patients that they think are at high risk for kidney failure. And so the question we asked the OHDSI community was, is there any evidence for doing that, for preferentially choosing ranibizumab to lower the risk of kidney failure? And so our hypothesis was that if we do pairwise comparisons between these medications, we're going to see a lower risk of kidney failure in patients exposed to ranibizumab compared to aflibercept and bevacizumab. So we asked this question and we conducted the study as part of the Save or Sisyphus or SOS Challenge, where in the course of 9 weeks, the whole community came together and we all learned about fun OHDSI tools and techniques in an effort to answer this question. And we used a bunch of OHDSI tools that I think Anthony Sena will go into later. And we asked this question across 12 databases, 6 administrative claims databases, 6 electronic health record databases that collectively had about almost 500 million patients. And we found 6.1 million patients with blinding diseases and 240,000 new users of intravitreal anti-VEGF medications, and found that overall, really, there was no difference in the risk of kidney failure in patients exposed to ranibizumab, aflibercept, and bevacizumab. So I can go back to my retina colleagues and confidently tell them that really, if you're concerned about the risk of kidney failure, you're really fine to choose between any of these 3 medications. And so I'm going to share the things that I learned as a result of doing this network study. I think things that I wish I had known before I started. So hopefully you can learn from my experience. For those of you who are clinicians or who are new at this, it's really important to kind of do the prep work and learn about the OMAP common data model, figure out what data types are available, learn about OHDSI tools, and really look at classical OHDSI network studies. I think as clinicians, you're really well poised to understand gaps in the literature, areas where you really need guidance to help you treat your patients and frame the right clinical question. But as with any observational study, using any research tools, not all tools are fit to answer all questions. And once you have an idea of your clinical question, it's important to form your multidisciplinary team, not just yourself, epidemiologists, biostatisticians, so you can bounce ideas off of each other and really use best practices from multiple disciplines to further refine your study question. And OHDSI has a lot of tools on educational materials that's freely available, but really nothing beats the experience of just talking to the OHDSI experts and people who are very familiar with the tools so they can give you a sense of what is and isn't possible. And as part of the study protocol, you'll have to develop your phenotype, develop your cohort definitions and make specific choices for study design. And I'd like to highlight the phenotype development. This is another area where I think clinicians have a lot of, resources to give. As clinicians, we see patients, we document, we have a sense of how well-structured data represents the phenotypes that we're interested in. So for example, intravitreal anti-VEGF medications are used to treat both diabetic retinopathy and diabetic macular edema, which are both manifestations of diabetic eye disease. But there's a lot of overlap between those 2 phenotypes, both clinically as well as in coding. So it would be impossible to do a network study looking at differences in outcomes in patients who get anti-VEGF for diabetic retinopathy versus diabetic macular edema, and clinicians can tell you that. So once you have your study protocol and you're ready to share this, it's important to promote your project, and I think the SOS Challenge is a great way to engage the community and get data partners. And one aspect of the network execution that I didn't realize was incredibly challenging was just the project management piece of it. Because so many people are involved, you have to keep track of who's doing what still needs to be done, and all the data partner restrictions that are out there. Like some institutions have to submit the abstract before you can submit it for public use, et cetera, things like that. And Jody Ann was very helpful in all of this, but as the study lead, it's still your responsibility. And once you've done your network study, you're super excited, now you have to summarize the work. You and your data partners have put in an incredible amount of time and energy to doing all of this. And so you kind of want to make sure everyone gets credit and also disseminate the knowledge that you've gained. And this is not a trivial task. Like for the anti-VEGF study, we are targeting primarily clinical journal because I want to share with my retina colleagues our findings because I think it affects how they take care of patients. But trying to translate all of the fine, technical details that were involved in conducting this network study into something that a clinician understands is very challenging. And I think this is where having a large co-author list and a very multidisciplinary co-author list is very helpful. The clinicians were able to identify areas that still didn't make any sense, that were still too technical, and the biostatisticians were able to identify areas that still needed more detail, for example. So hopefully, I've convinced you that network studies are really important and they can answer very important clinical questions because there's a tremendous wealth of data within this network. But it takes a lot of work, and it's certainly not for the faint of heart, but you can do it. So if you have any other questions that don't get answered in the discussion, please feel free to find me at the poster. Thanks.
Thank you, Cindy. Okay, next up, we have Seng Chan You from Yonsei University speaking about the fluoroquinolones and the risk of aortic aneurysm. Let's go to...
So, I'm Chan from Korea, and I'd like to share my experience to answer to the question, is fluoroquinolone use associated with the development of aortic aneurysms or aortic dissections? Fluoroquinolones are broad-spectrum antibiotics and has indications for many infections, including pneumonia, bone and joint infections, and urinary tract infection. It's generally well tolerated, even though they do have some common side effects such as vomiting, diarrhea, abdominal pain, and it also has serious adverse events such as tendon ruptures. So FDA warns the tendinitis and tendon ruptures associated with the fluoroquinolone from 2008. And based on the observational studies results, FDA starts to warn the increased risk of aortic aneurysm and dissections since 2016, and we start SOS Challenge from March to answer to this question. Aortic aneurysm is the ballooning of aortic wall, and it makes aorta very fragile. And aortic dissection happens when there is a tear in the wall of the aorta, and it is a highly fatal condition. Actually, my first case for mortality conference is the patients with aortic dissection. So in 2020, meta-analysis concluded that the aortic aneurysm or aortic dissection the risk of these conditions increases after the use of fluoroquinolone based on the 5 observation studies. But we found that there is inconsistency in these 5 studies in terms of include the patient's ages, follow-up durations, or we think that there is potential for unmeasured confoundings. There are, again, several papers reporting this associations from 2015, and many of these studies are published in JAMA Internal Medicine or JAG, which are the very privileged journals. But most of them actually have different study designs, and predominantly they report the results from single countries databases, and some of them does not define the active comparator or the indication of fluoroquinolones, and most of them do not measure the systematic bias. So Sisyphus is a mythological figure who represents repetitive and laborious task of pushing a boulder uphill. And to ensure that we have the right information, we predefined the diagnostics, and we decided to stop pushing boulder up the hill when the conditions aren't right. So based on our predefined diagnostics, if the study doesn't pass the diagnostics, we did not include we stopped just do the analysis. So we conducted this challenge over 9 weeks, and our target cohort is the fluoroquinolone with the UTI, and we chose 2 different active comparator, trimethoprim and cephalosporin, based on the treatment guidelines and usual clinical cares. Our primary outcome is aortic aneurysm or aortic dissection during 60 days after the initiation of drugs, and we used 50 negative controls to measure the systematic bias. The phenotyping is mainly led by Evan Minty. Thanks, Evan. 17 data partners joined the study across the artist network. We measured the balance by using standardized mean difference before and after pass matching. And we checked the empirical equipoise by observing preference score distribution, which is a transformation of propensity score. And we've defined that empirical equipoise when the more than 50% of patients overlapped between 0.3 and 0.7. So in this result, from the Optim EHR, the comparison between fluoroquinolone versus trimethoprim and cephalosporin has good equipoise, but both of them has more than 50% overlap in equipoise. But we found that preference of fluoroquinolone versus cephalosporin is not as similar as preference of fluoroquinolone versus trimethoprim in this database. And this is very consistent across the US databases. So the preference score distribution pattern is very similar across US databases. It's almost identical, but in non-US databases, there is less overlap between the two groups. And when we compare the fluoroquinolone versus cephalosporin, again, we found a very similar pattern across US databases, lower PS overlap, and actually there are higher PS overlaps between the two groups in non-US databases. When you measure the systematic error by using 50 negative controls, we found that 95 of negative control outcomes estimate has hazard ratio with confidence interval including 1 after empirical calibration, which indicates low systematic errors. This is the results. So the results of the hazard ratios and the diagnostics. And the shades are proportional to the PS overlap. Again, you can see very consistent pattern across the US databases and non-US databases in terms of PS overlap. Again, we only include the results passing diagnostics in the meta-analysis, and we found there is no different risk of aortic aneurysm or dissection associated with the fluoroquinolones. In our sensitivity analysis, we do not find the increased risk of these conditions in various time and risk settings or different outcome definitions. Actually, the risk of aortic dissection is lower in fluoroquinolone compared to the cephalosporin. So ideally, the possible results for one single question should be consistent across the different methods and databases. But usually, it's different. So the results published in the Internal Medicine shows neutral association, whether the study from JAG actually indicated the positive relationship. And our study shows the negative relationship in the risk of the aortic dissection. And distribution of positive results for one single question can vary across methods and databases. And that is why we need kind of this network study. So we need to assess the reliability of evidence underlying their decision. And we know that analysis of observational data are prone to bias. So we need, evaluate this bias, and we need to, measure the errors by using large-scale experiments across the large-scale database network of databases. In summary, we observed considerable heterogeneity in terms of characteristics of patients or comparative preference of antibiotics across various databases. And there is no consistent evidence to suggest an increased risk of aortic aneurysm or dissection following the use of fluoroquinolone in patients with UTI. Unfortunately, generalizability of our findings cannot be guaranteed to non-US countries because most of the results represent the US. Our findings suggest that relying on a singular database without proper diagnostics can potentially lead to unreliable evidence. And there is an urgent need for more analyst-ready standardized healthcare data worldwide to provide globally generalized evidence. Thanks for your attention.
Thank you, Chan. And so, lastly, but by no means least, we have Anthony Sena from J&J, and he will be speaking about the infrastructure learning across the network, applying the Strategus framework. Yeah, you're correct.
Thanks, everyone. My name is Anthony Sena. You can call me Anthony or Sena. Either's fine. And I'm going to talk a little bit about the lessons learned that we've taken from applying the Strategus framework across the network. So to start, we need to set the stage for what is the Strategus framework. And the Strategus framework is based on the Hades analytic libraries. And the Hades analytic libraries cover the major use cases within OHDSI for doing characterization, patient-level prediction, and population-level effect estimation. And the Strategus framework aims to create a standardized analytic pipeline whereby you create standardized inputs, so all of your study design choices are captured in a JSON document. That JSON document is then passed into Strategus for the study execution, and Strategus is responsible for setting up your R environment to make sure you have all of the necessary dependencies, as well as executing the study against your OMOP CDM. The output of Strategus is a set of CSV files, which provides transparency for the results that are generated by running Strategus and allows for inspection of these results before they are provided back to the study coordinators. So to start, we have to design a study in Strategus, and to borrow a concept from last year's symposium, we could think of the Strategus framework as building blocks, or maybe more specifically, Legos. And so to start, we have a set of Legos for building out characterization tasks, such as doing cohort incidents, cohort diagnostics, and characterization tasks. We have another set of Legos that are focused on population-level effect estimation for applying a cohort method, and the self-controlled case series. And finally, patient-level prediction and deep patient-level prediction Legos for doing those tasks as well. And so we can build up standardized analytics one Lego at a time. And Strategus is really the vehicle to allow us to transport those Legos to each site to perform a study. And I'd like to just point out that I'm still playing with Legos, and Martin's playing with large language models, so I guess, you can kind of see where we're at. But the Lego car is also small to show that Strategus is still under development and certainly needs your help to build it up and make it more stable. So the Strategus modules or Legos can be combined to accommodate various study designs. So this weekend when we conduct the How Often study, we're actually going to make use of two of the modules, the cohort generator module and the cohort incidence module, to conduct the large-scale incidence analysis that we're going to do. We might consider extending that at a later date to include patient-level prediction tasks, where we might want to build models to predict the outcomes for those populations. And ultimately, this big stack of Legos here is what we did for each of the Sisyphus Challenge studies that Cindy and Chan just covered. And so, as you heard from Cindy, we had a 9-week interval during the year where we talked about the Save Our Sisyphus Challenge, and we educated the community on the process of leading or participating in OHDSI network studies. And as part of that, we used Strategus to design both studies as a single JSON document and use Strategus to run both of those studies at different sites using the same infrastructure, which eases the burden of setting up and executing the studies. During week 6 of the SOS Challenge, Jenna Reps, Jack Brewster, myself, and Chung-Soo Kim provided tutorials to the community on how to go about using Strategus to run your study. It consisted of 5 steps for downloading the project, going through your configuration to connect to your OMOP CDM, executing the study using Strategus, how to go about reviewing the results, and ultimately sharing them with the network study coordinator. So one of the things that we did after that tutorial is we held office hours to share questions and issues that arose when running the studies. And it was gratifying for me as a person who was a bit nervous about unleashing this software into the wild for the network study to get on a call with people that were making use of this and potentially running into problems in their shops. When I got on the call, I was kind of expecting a lot of questions, which there were many, but I was gratified by the fact that many of the members of this community got on that call and provided not only questions, but solutions when they encountered those problems and shared those learnings as part of those office hours. And ultimately, they've become either patches that we've incorporated into the Strategus framework, or they're still on the roadmap for us to build. So what did we learn through that process? Well, one of the things that we learned is that standardization of your R execution environment matters, and it's not easy. And so the result of that was the Hades Working Group has declared an official R version that everyone in OHDSI should be using. Additionally, the use of tools such as RENV, which is a package manager for R, is necessary to control the R execution environment. And it's important that we are clear and declare the dependencies that we need to run each of our Hades analytical packages. And so Strategus makes use of this RENV technology to control the environment and to make your execution more consistent across studies. And finally, and this is not maybe a technical note, but more of a personal note, the collaboration is critical in network studies. There's no one person that's going to be able to do it alone. It is a team sport. And having office hours and Hades working group calls and Teams chats really helped us improve the quality of the Strategus software through this SOS challenge. And I'm happy to report and thankful for the community that we were able to run both of these studies across 11 sites and across 29 databases. So thank you to everybody who really hung in there and ran these studies at their respective sites. And the list of authors, which I didn't include in my slides, are on my poster. So if you could stop by poster 203, I'd be happy to thank them for you. So thank you. 203.
Thanks, Sena. Yeah, it was great to hear from all you four. And I think what these 4 talks have actually shown us is that there really has been progress made with regards to being able to get so many individuals, so many collaborators, organizations across the community to actually get involved and do these network studies. So I'm going to open up to questions. I have some that I shall fire at you. So my first one, I think, Cindy, you touched upon this. So I might go to Sena first, start at the end. So what do you think was the biggest challenge to running your particular network study? Obviously, we spoke about project management. What did you find?
I would say one of the biggest challenges was getting the individual execution environment set up. So folks had different environments from where I was testing. So I test on Windows servers with a Redshift OMOP CDM. Across the community, there are folks that are running things on Mac, they're running them on Linux, they're running them across a host of different database platforms, and they're also running with different versions of R installed in their environments. So trying to get over some of those hurdles was a challenge, but again, the community was very helpful in both patching some of those and identifying some of the issues as they came up.
Fabulous. Chan?
So the biggest challenge in the network study would be the, calling the data partners. So it's for me, even for me, it is not really easy to make people join the study. And actually, it is not easy for me to join the other studies because I need to submit the IRB first, and then need to be approved. And the challenges remains after the executing the studies. It's really hard to summarize the results from the network study because we made just tons of the results. So there are some people agree with me. So even for me again that it is really challenging to summarize the results, and it's very hard to make one single conclusion because the results can be very heterogeneous across the databases, and we don't know the exact reason why it is so different across the data network. I don't know why the preference is so different between the countries or the databases. So again, it's very challenging, but it's worthwhile. Thank you.
Would you like it?
everything. So, running network challenges is very, very hard. I think, because I have folks like Anthony Sena to rely on to make sure Strategus runs, and, Marc Suchard to make sure it runs on the VA database, I would say as a study lead, the hardest thing is probably just coming up with the clinical question that you think is relevant and is answerable within using OHDSI tools. Because once you have that, then you have an entire community who can help you with the logistics and actually executing the study itself.
I feel my colleagues have done a wonderful job in highlighting some of the larger problems. I mean, I certainly don't want to steal Chan's thunder, but I will reiterate the point that after the execution, there's the evidence synthesis and the then delivering out to the larger community. And that piggybacks very closely to starting off being engaged with an important clinical question. These are my personal feelings. I think as a community, we have done an amazing job in standardization, starting from standardization through a common data model, standardization of tools that will execute across this data model, and that has made these types of studies much easier. I know you said everything was difficult. Imagine trying to do that 10 years ago. It's almost unimaginable. So I think we should certainly congratulate ourselves on that success. But before you clap and congratulate yourself, we have abjectly failed on the next step. And that's providing standardized tools that allow us to synthesize and then deliver this evidence in a way that's actionable not only in our community, but across healthcare and clinical practice in general. So perhaps a goal that we should set for ourselves are the standardization of that type of write once, think very deeply, and then impact a whole lot over and over again. So hopefully in the next year we can make some progress in that front.
Now can we clap?
Yes.
Muy, you may.
So one thing I'd like to ask is around engaging the data partners for each of the studies. So how did you go about actually engaging them, certainly at different levels of preparedness? So for example, there are some partners, some databases that need IRBs, ethics, approvals, that sort of thing. So how did you manage that? How did you then engage with those partners and ensure that you were able to deliver what you needed and on time?
So I'll lead off very briefly by saying, I have an unfair advantage of some long-term relationships, but that's part of the open community is kind of to build those types of relationships to make this type of network and collaborative work on a global scale. So I'm actually going to defer to individuals who are now sort of building up to hear about what were the successes in building those relationships.
I think, yes, everything. So I think this was definitely an issue that we came up against in the anti-VEGF and kidney failure project. We have an amazing eye care and vision research work group over there. Clap, clap, clap. Who, we had lots of data partners who were super excited about the project, who really wanted to participate, but everyone was at different levels of readiness. Some people didn't have an OMOP instance. Some people had a hard time getting through the IRB. I think we successfully got USC with Brian to join in on our project, but many others wanted to participate. So I think I would love to see some perhaps standardization and bringing partners on board, efforts in that arena so that we can engage more institutions.
Sure, many one ask me how to do OHDSI study and how can I learn the OHDSI network studies. And my answer to these questions is that joining the other study first. So by joining the other study, you can learn about how you can execute the study, how you can make very good question for this network study, and what would be the challenges across the studies. And and by contributing your data to others, that you can make some very good relationship within this community. And actually, again, I think that we need more evidence for APAC regions and European regions. So that's why we are trying to join more and more studies.
I guess I don't know, but I know that you all get my email address somehow and then email me when you have questions or challenges, which is awesome. And I think for me, part of what these network studies have shown me is that we have to build trust within our own community so that we feel good about running these studies. And from there, we can kind of move up the chain as we saw with the Sisyphus Challenge. So yeah, just keep pinging me in Teams. I'll eventually respond. But yeah, I think just building that trust.
Fantastic. So obviously some of these studies are huge. We're talking about large-scale analytics. There's a ton of results. How has that been dealing with that amount of results from various sources?
Do you go round robin or?
Yes.
No, I don't.
So I guess I'll go. I guess for me, at a technical level, there are challenges just in terms of scale. So just a shout out to Lee Evans, who always keeps our infrastructure up and going. Just loading all of those results and kind of keeping that stable is a task on its own. But then I think the bigger task that Marc pointed out is how do we actually go about sifting through all of the data that's generated and actually come up with actionable evidence from that. I would echo his sentiment that that is something we should tackle or start to tackle.
So the heterogeneity across the databases can be a weakness of network study. So we cannot, sometimes we cannot find a very consistent result. But again, I do think that this is a strength of network study because there is a heterogeneity. That's why we have to run the study across the databases to find more reliable evidence.
I would agree with Chan. I think the heterogeneity really is a strength, but it's certainly challenging to summarize it for a journal. I think it's useful to keep in mind who the target audience is of a journal. Like what I would write for an informatics journal is very different from how I would present results and perhaps what results I want to highlight for a clinical journal. So having that background might be helpful.
And to build on that, our work targets, it's cross-disciplinary. It targets several different fields where individuals come with very different skill sets, from the clinical through the informatics, and might I say, all the way to the mathematical and statistical for the statisticians among us. I know there are a couple of you, and no one's going to applaud for you, but I appreciate every single little bit that you're doing. And it's thinking about how to communicate between these disciplines to pull this together. And I don't have solutions to that problem at all, but I think over the next 2 days, particularly when we're sitting and working together in the how often work group, one of the discussion points and an activity that I'd like to task each of you with is go talk to someone with very different training and find out what are your differences both in the understanding of the problem you're working on and how you're executing it. And bring back that knowledge in how can I start to build this kind of bridge, even amongst ourselves, so that we can start to target these different audiences. It's hard. Everything is hard.
Great. So we have everyone on board. Everyone can see the potential here for the network studies. But what advice would you give to someone who's wanting to starting their own network study? So completely from scratch. What do they need to do? What advice would you give?
2 bits of advice that I'd start with, but I think they're going to be echoed by others. This community is incredibly open. And for the individuals where this is probably your first time here, it seems unbelievably, even incredibly, like you don't believe it, how open it is. But it's not a lie. You can reach out to anyone. If you're interested in running a network study, just interested, you're like, I don't know how, find an individual, make a friend, come talk to me. I can introduce you to folks who might be interested in helping you push your problem forward. Within the community, I'm hoping we'll do things perhaps not called the SOS Challenge, but something very similar, where we get behind 2 to 4 new individuals who are interested in pushing forward important clinical questions each year or every couple of years. So that would be a great vehicle to get your feet wet. So I guess I'm going to rephrase that question a little bit to the individuals who just got their feet wet and say, did it help, or how did it help you?
Yeah, I'd love to share my experience with OHDSI and OMAT. I came to this symposium last year with this harebrained idea about anti-VEGF medications and kidney failure, actually just kidney stuff complications. I wasn't sure we wanted to look at kidney failure. So I went up to Patrick and told him my harebrained idea and told him how lacking the literature was in answering this question. And he said to me, we can do that. And so I think that's how this entire network study happened, just from talking to people who are willing to talk to you back.
From my perspective and background, yeah, many people in this network should learn English first. So, especially in those in Asia, we have to learn English. So that's the first step to do the network study. And again, that during more meetings, of course, it's in English. So, it's so suffering, but. But yeah, that's very important. Communications is very important in this network.
I guess another language you might want to learn is SQL. So that always helps with network studies. I would say as a technologist first, it's been really amazing to work with many of the people in this room on network studies, because it's a first in my career where I write software and I test it, and then I say to you guys, just go and try using it in your environment. That could be vastly different from mine, and it's been an education on its own. And I think if you're interested in that aspect of network studies, it's awesome to get involved and provide support.
Sena, you'll always be a select star to me.
That means a lot, thank you.
No, that's great. So everyone's excited. Yeah, you've got some ideas for some network studies. See a lot of work coming through. So yeah, I mean, does anyone have a burning question that they would like to ask the panel? Yes, please. Morning.
Except morning.
Except morning. No.
Shout.
Check. No, okay.
Oh.
It works now. Okay, fantastic. Yeah, thanks a lot for the panel and Sarah for the very informative sharing. So for network study, is there a fair estimation on how much effort is needed to lead and start everything from scratch for a new network study? Just want to prepare anyone that may share similar interests, mentally. Yeah. Marc,
Go on,
go.
Marc.
Marc is like, oh.
How long's a piece of string?
I think a fair estimate is 1 FTE.
For a year.
Yeah. Now that doesn't have to, it's not one individual. But I think Cindy would say she's been almost full research time for 4 months. And she is one of 20 plus people helping her on a regular basis. And maybe my 1 is a little small now. I think about the amount of time that Sena has put into the SOS Challenge. He's put in at least 2 himself. It's a tall task for one person, but as I look around the room, we're certainly not one person.
So, sorry, one follow-up.
Hey, you only allow 1. Come on.
Okay.
Stop cutting in.
Come on, half. A quick one. You mentioned that obviously we need a cross-disciplinary team to make it work. So among the team, sort of the 1 FTE, what are the key roles among the team? I know that we need a huge team to work together, yeah. So what are the key ones that we must find these key personnel to make sure that it's successful?
My role in the SOS team in my case, was that simplifying the question. So, do not start with a very complicated study first. So I really tried to make this question as simple as we can do. So my recommendation is to do the simple study first.
All right, now sit down. Good, thank you. Sorry. I could ask my question too, This is more directed to Cindy. So sorry to put you on the spot. As a newcomer, like you said, right, you're a physician, you've not done this in the past, and suddenly you were given this wealth of tools and people to help you make this study possible. How did you trust it?
How did what?
How did you trust what we did?
Oh, yeah.
Right? I'm gonna ask.
No, came to the OHDSI Symposium last year, and I became a believer. I think there's just so much evidence and so much science that goes behind each and every single one of the tools. I had an amazing amount of trust in the results that I was being given. That was never part of the doubt. Now, understanding what the results were, that was a much bigger challenge.
And I think one thing I wanted to add is that obviously it takes, a bit of an army, or should I say a community, to actually get these efforts up and running. But at the same time, don't be put off by that. You can sort of contribute as much or as little as you want, even if it's just the beginnings of an idea. Come to us, come to Patrick, come to anyone, to the entire community, go to the forum, put it out there. There are plenty of us that will want to be involved, so please do. Don't be put off that it needs a lot.
We got two more questions.
Okay.
Hi, I have one question for Cindy. Cindy, I think you mentioned that one of the challenges was to convince the data owners to join the network study. In your mind, what was the biggest obstacle on their end to contribute their data? And what do you see as a potential solution to address that?
Yeah, and I think this was something Chan alluded to as well. We didn't have a lack of enthusiasm for this project. I think a lot of it just came down to logistics and time at each individual institution of people who can put in the effort to submitting the IRBs and running the Strategus package and making sure it runs in their environment. That takes a lot of work. And so I think the institutions that ended up contributing are places that have existing infrastructure to run network studies. So that could be something that we invest in as a community.
Yeah, we need make a trust across the community that contribution of data is actually helpful for the data owners. And I recently published a paper about building the CDM network for our Korean nationwide claim data, and I argue that the nationwide data should be equitably accessible to all researchers inside and outside of Korea. So that's what I argued.
Okay, we have time for one more question.
Great. I'm about to run a network study, and I wanted to hear your thoughts on if you have gotten return like a non-human manageable amount of results, and what you did, and whether you kind of found some solutions through visualizations or other tools. So I would like to have your opinions on that. Or maybe it was not the case.
So yeah, it's very challenging. So I usually uploaded my code to summarize the results. So you can use my R code to summarize your network results, the results of your network studies. And actually, Marc published lots of R codes to summarize the results, so you can use it too. But once again, you can just ask help to the community.
Perfect. Well, I just want to say thank you to our 4 panelists. So we'll give them one last round of applause. Thank you, guys.